All right. Hello, hello. Welcome everyone to a Tuesday virtual morning report. It's so wonderful to see everyone tuning in. So welcome, welcome. Um, Today is an exciting day for the morning report today. Ravi and Hans will actually be discussing today. So we're really excited to discuss a case and all learn together. So as always, we'll lean on the crowd to see if any of you guys have a case that you would like to present. It's always really fun to kind of crowdsource a case out there and see what we can learn from you. So please unmute or put your name in the chat if you have a case that you would like to present. Ravi, how are you?
I'm doing very well. Thank you, Madalena. And thank you for the introduction. And it's always great to be here on Tuesday VMRs. We don't have neuro VMR this week, but we'll try and fill in this slot with a regular VMR. Before we get underway, I'll have Hans introduce himself. Hans?
Yes, my name is Hans, and I'm a recent medical graduate. And yes, I'm at Ross University as a clinical skills facilitator. And
Awesome. Thanks, Hans. You're always very helpful on the platform and always discussing. And a great case last week. I really enjoyed your case. I also want to say hi to Leah and Yasmin's here as well today. And I see a student of mine, Shelley, who presented a great case earlier on in the year. How are you doing?
Good. How are you?
Are you off?
Yeah, I'm just doing interviews, so I haven't been like actively in the clinic or hospital, but it's been going well.
Awesome. I always tell all the students coming through about you and your fantastic double endocarditis case on student VMR. So it's great to see you here and good luck on the interviews. Still waiting to see if anybody has a case.
Yeah, last call for anyone if you have a case, and it doesn't have to be fully well prepared. It could just be something that you saw in the hospital or clinic recently. So definitely don't hesitate if you have a case. We would love to discuss it all together. All right. Let's see if the silence has motivated anyone.
How was your weekend, Madalena?
My weekend was wonderful. Thanks for asking. My brother came to visit me, and we went out to dinner and went on a nice hike. So it was really wonderful. What about yours?
Oh, great. Yeah, I didn't do much. I did go to a football game, the Broncos
nice.
versus Ravens. So it was interesting. I almost left the game. It was not a very good game until the last 2 minutes. So I'm not sure if anybody follows the NFL, but I know they recently played in Germany. Leah, are you familiar? I know the World Cup is going on. And Leah, are you familiar with the NFL? They recently had a game in Germany.
No, unfortunately, I don't really follow it. So I'm afraid I'll have to disappoint you for this one.
No problem. I know you're next door to Germany, as you're from Austria. How you been? A long time no see. It's great to see you here today.
Yeah, it's been good. I think I haven't been much around because I started my clinical rotations a few weeks ago. So it's been really nice getting some practice and interacting with patients. I think it's a very new phase of my training now. So yeah, been enjoying that. Many new impressions.
Yeah, I'm sure you're going to do well with all the knowledge that you gain from CPS.
It definitely has helped. Yeah. Just already training the clinical thinking before, I can see how much that makes a difference. Awesome. Yeah, but there's still lots to learn. That's for sure.
Oh yes, that's the main driving force for me to come here again and again, is you always learn something. So We always striving to learn.
Well, I don't see that anyone
Yasmin
has come
has a
through.
small one, not
Oh, go ahead.
neuro though. Yeah, we don't have neuro VMR today, but you have a small one. Okay, by all means, Yasmin, if you're able to present from memory.
Yeah, I had one, and maybe well, I won't say anything else because people who are like regulars and VMRs, if I say anything else, they will be like, oh, it's this one. They will know the diagnosis, and I think I gave myself out a lot. So well, this is the case of a 48-year-old female with severe abdominal pain and fatigue.
Interesting chief complaint there. Hans, would you like to take a stab at it?
Yes, so we have a 48-year-old female, abdominal pain and fatigue. I would look at both separately at first. Abdominal pain, we need more information later on concerning time course and location, etc. But with this information, I would just look at all the organs in the abdomen to get an idea what it could be, from the liver, stomach, the diaphragm, which is bordering the abdomen from above, maybe the spleen. If it is more on the left side, maybe it is diverticulitis. And then more lower abdomen, it could very well be from the pelvis, her bladder. So, and for the age, she's still at an age where we might have to consider OB/GYN problems as well, even pregnancy or an ectopic pregnancy, which could be abdominal pain related. Now, fatigue, here I'm not certain because it's a very wild or unspecific symptom, which ranges from anemia to infections, chronic infections, immunological problems, or even malignancy. So I'll have to see how this evolves.
Hans, that was very well put together. I really like what you just mentioned there. We have two simultaneous events going on. I think the lesser one may be fatigue. The one I would be really anxious about is abdominal pain. And as you correctly associated the age here, does the age dictate something that's parenchymal? And like all the fabulous organs that you mentioned, you could associate with patobiliary, with the digestive system. There's just so much in the abdomen that could signal disease here. But I always like to start, I do a medical simulation with students and residents. I always like to start with the mnemonic VIPOE, which is looking for the life-threatening causes of abdominal pain. So V would be vascular, like mesenteric ischemia. Itis, so itis could be anywhere, diverticulitis, duodenitis, appendicitis, cholecystitis. So any itis, major inflammatory condition of any of the organs that could that needs actually surgical intervention other than diverticulitis. P, perforation, O, obstruction, and E, I really like that you had focused on the gynecological organs there. Sometimes we do forget, and there's been many cases where young female may come into the emergency room, and we being focusing solely on medicine may neglect the OB part of it, but ectopic pregnancy definitely is something that's life-threatening and we have to consider. So I would start early with something like this, but then I would depend on more information in the further aliquots to see what's unfolding in front of our eyes. Back to you, Yasmin.
Of course. Now, this abdominal pain started approximately 2 hours ago and is very intense. It's located in the right flank and radiates to the pelvis. She has had constipation for 6 months, and she also complains of nausea that started 3 months ago that presents for the entire day and worsens with meals. Also, the fatigue started for like 3 months ago. Should I go on with meds and past medical history?
Yes, please.
Okay, so For medical history, she has history of kidney stones. She has had kidney stones 4 months prior to this presentation. And she has hypertension, for which she takes hydrochlorothiazide.
Aha.
That's it.
Hans, would you care to take a stab at this one?
Now our attention includes the kidney as well. So intense pain that started 2 hours ago, that would mean it is acute. The pain is located to the right flank, which would indicate the right kidney, radiates to the pelvis. So we might even think that maybe there is another kidney stone on its way down to the bladder with a big question mark, because it should have been noticed earlier. Constipation for 6 months, nausea for 3 months ago, worsens with meals. So here we are probably focusing more towards a gastrointestinal problem as a possibility. So we have kidneys and some gastrointestinal problem. Right side, so that points more towards the liver, maybe towards the gallbladder, or even the appendix. I would like to add this one as well, because I don't have the exact location, but the appendix does not radiate to the right, to the, maybe it does, depending on its location. So I'll be open.
A great analysis there, Hans. I'm right there with you with trying to think about now geographically, we're in the right side. So if I go from top to bottom, like you'd mentioned, you got the hepatobiliary system, you got the ascending colon, you got, and then the terminal, the small intestine also meeting at the cecum. So any inflammation or any pathology could be maybe confined to that area, but like mentioned, it could radiate. It could be, pain could be radiating from somewhere else into that region as well. Radiating to the pelvis, this constipation. So what radiates to the pelvis, usually like with cholecystitis, hepatobiliary, could radiate upwards, maybe above the diaphragm. I don't know if it usually radiates down to the pelvic area. Are we dealing with then the kidney in the retroperitoneal region? We have kidney stones here. Does this help us, or does this provide diagnostic clarity? I'm not sure. Maybe this could be another episode of nephrolithiasis, maybe plus or minus inflammation, plus or minus infection that could be occurring here. Certainly don't know. The medication here, HCTZ, does that lend any complication to this? Could this explain some of this? I don't think abdominal pain, maybe as a diuretic, could cause dehydration, maybe also cause hyponatremia. So metabolic disturbances could very well manifest with abnormalities with the GI system. And you have constipation. Is the constipation primary or secondary? Is probably secondary to whatever is going on. Even an organ that's inflamed in proximity to the colon could cause sometimes diarrhea, could sometimes cause constipation. So it can be a noisy neighbor and cause disturbance to the surrounding structures. Inflammation can permeate beyond the borders and confines of an organ. So if you have like a pyelonephritis, the surrounding structures may actually also be disturbed. So I'm still not sure what we're dealing with. The fatigue, the nausea, this could all be secondary, non-specific, but again, it all points towards the gastroenterological system. The right side, again, the structures running from the liver, gallbladder, retroperitoneum, the kidney, the adrenal glands there as well, and then the ascending colon down to the cecum, terminal ileum. So any one of those could be at play for causing this presentation. And then also in the 48-year-old, we have to think about the right-sided nexal structures. So ovary, the tubal system, and rest of the gynecological structures we may also have to consider. Oh, Hans, you had a thought there. that you put in the chat.
Yes, when I just look at nausea 3 months ago worsens, it's just the point that it worsens with meals. It doesn't 100% fit, but it might. Maybe she's pregnant and it's an ectopic pregnancy. But for 3 months, it should have manifested itself much earlier. But because of the acuteness, started 2 hours ago, maybe we have a perforation of one of the adnexal structures. It would explain.
Yeah, that definitely would be, because this pain has just started 2 hours ago. So something just suddenly just occurred, and what could happen in the abdomen that could be very catastrophic and cause tremendous pain within the duration of a few hours. So perforation, definitely obstruction. If we do have a perforation, would you look for abdominal distension, maybe peritoneal signs as well? So there's a lot I'm sort of anticipating obtaining from the examination and vital signs as well. I think we're not seeing anything relating to the hepatobiliary system, say like jaundice. The patient's not coming in with findings of jaundice, no stigmata of any chronic illness like liver cirrhosis is particularly not mentioned in the past medical history. So I am moving away from the hepatobiliary system more to the other structures, and I like that theory of ovarian torsion very much. Back to you, Yasmin.
Of course. So here, for the labs, the vitals, it is not reported, just said that it's normal for temperature, heart rate, blood pressure, all of them are reported as normal. The patient is reported as anxious, she seems fatigued, normal examination, sinus rhythm for cardiovascular, no rubs, no gallops, normal cardiopulmonary. For the abdomen, there's a colicky flank pain that radiates anteriorly to the abdomen. And there is pain to the rebound. And that's all it says. Reduced bowel sounds, neuronormal, and extremities also normal. It's not reported. Should I give you labs?
Yeah, I think so. We can tackle exam and then labs, but yeah, go ahead.
Okay, so we are not given hemoglobin or white blood cells. It jumps directly to the chemistry. The sodium is 138, potassium is 4, calcium 11.5, creatinine 1, and phosphorus 2. And that is for the labs that we have.
Okay, great. What do you think, Hans?
Well, I thought when I looked at colicky flank pain radiates anteriorly to the abdomen, maybe there's some obstruction and perforation. But now, of course, looking at the chemistry, she has, I think, 11.9, 11.5 is elevated with a phosphorus around 2, which is, it was already mentioned, it is low. So there's more going on.
Yeah, the other domain that we didn't look into is metabolic disturbance. Patient is constipated. So what could cause constipation? Metabolic disease, definitely endocrinopathies, hypothyroidism, and then the calcium. And I'm not sure if this is corrected, but 11.5 is high enough to
Cause constipation.
Yeah, cause constipation, and also all of the different side effects of hypercalcemia. So the phosphorus is also, it's 2, I think it's 2 is low. And then does this direct us towards a PTH mediated process? Like last week we had a PTH hyperparathyroidism due to pituitary adenoma. And what does the parathyroid hormone do? It will absorb calcium at the expense of phosphorus. So the phosphorus will be low, as could be in this case. So definitely would want some more information, as the chat's alluding to. We'll need a PTH, we'll need If the PTH is elevated, then we'll have to go down that branch point. Otherwise, we'll have to look at non-PTH mediated processes, namely maybe looking at vitamin D and other disorders as well. So do you have the next aliquot? Yasmin, thank you.
Yeah, so the primary, the PTH was high, and that's the only other lab that is given in this very short case. We have the abdominal ultrasound that showed right kidney stone. And we also have the USG of the parathyroid. Do you want it?
Well, let's stop here for a second and
Okay.
see now with this information, what can we glean from this? You want to take a stab at it, Hans?
We already got a very, very important clue, PTH high and high calcium. So we are thinking already, just like in a previous VMR session, that she has a hyperfunctioning parathyroid gland, so a parathyroid adenoma that causes hypercalcemia, which in turn can be the source of kidney stones. And that indeed explains constipation as well for 6 months. So it's been going on for quite a while. Hypercalcemia also explains nausea, and it might, as a matter of fact, explain fatigue as remotely as a possible psychiatric undertone that we might see, or just the fact that the metabolic derangement might cause fatigue. So I'm very much inclined.
Yeah, it's very interesting that this is such a devastating presentation of hypercalcemia, and this probably didn't happen immediately. This has probably been going on for quite some time, as this patient's been having some symptoms for a relatively long period of time with this acute 2-hour pain, which could be brought on by constipation. And I've been fooled many times by constipation causing tremendous abdominal pain, causing vomiting, causing pain radiating to the back, and colicky like this. So I've had patients with pain that almost appeared surgical. And long-standing constipation could manifest with perforation. We did have a patient that suffered a colon perforation due to tremendous constipation. So yeah, here, what is also interesting is I was thinking about the medicine, but I didn't really pay it much attention. But HCTZ can be a cause of hypercalcemia, but this would be in the bucket of non-PTH, PTH-mediated hypercalcemia. But HCTZ combined with a elevated PTH, you got a double whammy here. And by discontinuing the HCTZ, you may actually bring some of that calcium down, but it won't explain the phosphorus being low as well. And the right kidney stone, the kidney stones are explained by this. So a patient having recurrent kidney stones, you would take a look at the calcium to see if that's probably causing these recurrent stones from forming. And that can be a very, very painful process. Yasmin, you have the next aliquot?
Yes, just they did a USG, parathyroid USG, and a system scan that demonstrated a right lower parathyroid adenoma. This patient underwent parathyroidectomy, and after this, she had 2 weeks of hypocalcemia that required treatment, but that's everything else that was reported in this case.
Fascinating. This is great. I'm learning so much hypercalcemia again. Yeah, I just love it. But you know what? What really what would throw me off is just the devastating presentation. It just doesn't feel like a case of hypercalcemia, but just like Hans mentioned. Now, if you look at it again, maybe because she's younger, in an older person, the effects may be more drastic. But in a younger person, a lot of these things can be masked or maybe less severe until it sort of bubbles under the surface and then just boils over with such a devastating presentation. Hans, any reflections?
Yes, I think now we can explain in all likelihood the extreme abdominal pain as well. It was already mentioned here. It was another kidney stone secondary to her hyperparathyroidism. So she constantly developed kidney stones. That's how it more or less looks like it. And I think it all falls into place almost.
Yeah, definitely. And yeah, if you walk it back, having HCTZ on board also wasn't helping the patient. So if you think about it, Lasix will help with excretion, HCTZ will help with reabsorption and cause this recurrent hypercalcemia. And two things that come to mind that you definitely must know about when dealing with hypercalcemia is the reasons for parathyroidectomy. And then the other thing is a condition that can happen once you remove the parathyroid gland, something called hungry bone syndrome. So two things that also go with learning about this condition when you treat a parathyroid adenoma. And like last week we had mentioned, we see parathyroid adenoma more commonly than hyperplasia. And if you look at the epidemiology, the patient last week was in the 70s, and we found one statistic that patients usually manifest in the 70s, but this is a much younger patient that falls outside the curve. So definitely in an older patient, you may see all the complications, as in that mnemonic we always talk about, psychic groans, moans, abdominal pain, overtones, and so on. I keep forgetting what it is, but what we commonly use when we learn it for USMLE Step 1. Back to you, Hans. Any more thoughts before we wrap it up?
No, I think we can explain everything. So it was one underlying reason. Yes, the hydrochlorothiazide, even if she was entirely healthy, it is decreasing the calcium in her urine usually, and it makes the calcium go up in her blood, but that is nothing which causes hypercalcemia. It is still very well balanced. So I have nothing else to add other than thank you very much for the interesting case.
Yeah, same here. Yasmin, I really appreciate you recalling that small case from memory. I actually had a lot of fun going through it. We'll go on. Yeah, it was great. I really appreciate it. We'll go on to the teaching points.
Of course. Very short. Sorry, I was like trying to describe and in this case, with a woman that presents with abdominal pain and fatigue in ER, we must consider gynecological issues such as ovarian torsion. We can start with IPOE, with vascular itis, which can be any major inflammatory issues, perforation, obstruction, and E for ectopic pregnancy, for example. The pain localization helps us determine the main issue. In nephrolithiasis, it's helpful to determine if there is concomitant inflammation or infection of the kidneys. Also, metabolic disease can cause constipation, such as electrolyte imbalance, especially hypokalemia and hypercalcemia, hypothyroidism, diabetes mellitus, hyperparathyroidism, and heavy metal poisoning, especially lead. And when treating parathyroid adenomas, beware of hungry bone syndrome, which is a state of profound hypocalcemia, which is challenging to control after a parathyroidectomy or thyroidectomy. So for the treatment, I couldn't finish copying it. If the serum calcium level is less than 7.6, if the patient is symptomatic, if there are EKG changes such as QTc prolongation noted, we have to start treatment with intravenous calcium. So calcium chloride or calcium gluconate are the treatment of choice. So this is for the spaced repetition studying of hypercalcemia.
Thank you very much for the teaching points, presenting the case and also doing teaching points. So thank you very much, Yasmin, for that. All right. See you everybody tomorrow. Tomorrow we have another VMR. I think it's at 12 p.m. Who's on tomorrow? Is it?
I believe it's Stefan Zavin who will be facilitating.
Oh, that would be a delight. I haven't heard from them in a while, so I'll definitely log on for that. But definitely everybody log in tomorrow and we'll hopefully listen to another fantastic case. Take care. Have a great rest of the Tuesday. Bye.